Hello, and welcome to another In Search of. Welcome to New Hope Seventh Adventist Church Women's Ministry Program, In Search of, and we search for the intriguing, the informational, and the controversial from a spirit-filled perspective. We're located in Fort Lauderdale, Florida, and my name is Marie Brathwaite. Let us pray. Father in heaven, we just thank you for the opportunity where we can gather together to grow and learn new information that will somehow help us or others as they listen in and take in what we have to say. This is my prayer in Jesus' name. Amen. Okay, so tonight we're going to explore mental illness. This has been for the past year or so with the pandemic, we've had a lot of talk about mental illness and depression. Mental illness is a wide and overwhelmingly diverse subject. So in order to narrow it down, we're just going to focus on bipolar disorder and schizophrenia. The title of the program is Before the Storm, and it covers the causes, the symptoms, and the treatment of mental illness. We invite you to go ahead, and if you have questions, this is interactive, so if you have questions, please type them in the chat, and we're going to do our absolute best to answer them. Okay, joining me today, we have two highly respected guests. We have Dr. Perdomo. Dr. Perdomo is a native of the Dominican Republic, where he was educated and received his MD license from Intech University. He emigrated to the US, where he completed his specialty in psychiatry at the University of Miami, Jackson Memorial Hospital in Miami, Florida. He then solidified his training at the psychiatric facility, Three Rivers Behavioral Health in Columbia, South Carolina. He is currently working as a psychiatrist for the Broward Health Systems. He works with all age groups, from children to geriatrics. And then we have Miss Joelle LaGuerre. Joelle is a freelance organizational development consultant, a leadership and life coach, and the founder of ProU. Through her business, she helps organizations and individuals thrive, most often by helping them to integrate positive psychology principles and techniques into work and life. Psychology and human behavior has always been Joelle's passion. She has an undergraduate degree in organizational psychology from Oakwood University and is now completing graduate work in coaching psychology from Life University. Before stepping out on her own, Joelle held program management and leadership roles in human resources, specifically learning and development, in private industry, higher education, as well as the federal government. Originally from Miami, Florida, she now resides in Washington, D.C. I welcome you both to this program. Okay. I wanted to learn more about these two illnesses because apart from depression, I think these are the two terms that I've heard most when people are talking about mental illness or they encounter someone suffering from mental illness. And I wanted to understand more about them. From my untrained view, people are fine until they're not. So, is bipolar disorder and schizophrenia a form of depression? That's my question. And I'm going to start first with you, Dr. Perdomo. Could you, for us lay people, tell us what is bipolar disorder?
First, I just want to say thank you. Thank you, Maury, for inviting me and for that nice introduction. But nice to meet Joelle as well. And I hope I learned a lot from her too. And thank you everyone for having me, and I hope I'm able to provide some information and some clearance. So yeah, so okay, so let's start. So bipolar disorder is it's one of the most common mental illnesses. Um, it it is a mood disorder affecting mainly people's mood. But bipolar disorder can include depressive episodes. So, sometimes it presents as if it was the same as a major depressive disorder or major depression. But bipolar disorder also has the other half of it, which is what people call mania, which is uh, in lay terms is the opposite of the depression. Whereas in depression, a person's mood goes down to pathological levels beyond the normal sadness. Mania is a situation in which a person's mood is elevated. It can be exaggeratedly happy, what's called euphoric, or exaggeratedly angry and irritable. Um, Also accompanied many times by exaggerated anxiety, and it's an illness that has many components of it, but that's basically the everything comes up from that exaggerated elevated mood with elevated anger and or excessive happiness, and the increased energy that comes from that.
So in other words, okay, so bipolar meaning it's two polar opposites. So you have
Yes.
on one end severe depression or just depression, severe depression, and then the other one a total opposite to depression. So it could be anger, it could be happiness, but over exaggerated. So
Yes.
that is where the term bipolar comes from.
Yes.
Okay,
Yes.
okay,
And yeah,
go ahead.
I was just gonna say that clinical depression, which we call also major depression or major depressive disorder, is also called unipolar illness.
Oh,
So that's where the bipolar is from, that you have both extremes.
I see. I see.
Yeah.
Nobody ever explained that before. Thank you.
Okay. Oh.
Okay, so how does somebody get it? Does it is there a particular cause? Are they born with it? Does
So
drugs cause it? I what?
so no. So far, we're still learning about these illnesses, both bipolar and schizophrenia, and especially I would say over the last probably 10 years, with the new knowledge that we have acquired regarding the human genome, and they've been studying all these genes, and we're getting some new information every day. It is, it seems, basically, it does seem to be a genetic condition,
Oh,
meaning that there are, we've found several genes that are associated with bipolar disorder as well as schizophrenia, but we can talk about that later. Some of these genes are inherited. There is a big percentage of the illness that is inherited. Usually, if someone has an immediate family member, what we call a first degree family member, like a parent or a brother or sister, that has bipolar disorder, then there is about usually more or less around 50% chance that a person could potentially have bipolar. Having said that, it just because it's a genetic illness doesn't necessarily mean that it has to be inherited. There also seem to be some gene mutations that happen sometime in the process of development of the person, that can increase the chances of someone being bipolar. And sometimes you can have people who have bipolar disorder who have no family history of bipolar disorder. So in these cases, those are people that had some genetic mutation at some point. Having said that, what you inherit is the likelihood that you're going to develop bipolar disorder. But there are certain things that definitely can precipitate the onset of bipolar disorder. And we can talk about that later, but you would have to have the genetic predisposition to develop bipolar disorder.
So you're saying that if I do not have that's fine, and bipolar disorder within my family, the chances of me becoming bipolar are very slim.
Yes. Definitely, if you don't have it within your family, the risk is smaller. Like I said, some people sometimes develop the genes through mutation, so it's not impossible. It can happen, but definitely it decreases the chances if there's some sort of family history of mental illness.
I remember way back in the day when I was in college, and the in thing was to smoke a joint, and then you heard about it being laced with something, and then I personally experienced people who smoked a joint and then became mentally ill, but that was not bipolar.
No, well, so this is where it can get a little complicated, and where a good family history, it's very helpful for us mental health professionals, psychiatrists, psychologists, therapists, nurse practitioners, and everyone else, because there are different things. So like I said, people who have bipolar have to have some sort of genetic predisposition for it. However, many times the event that precipitates the first episode, it can many times be the use of drugs such as a joint. People think joints are innocuous, and definitely they do have their medical uses and their advantage, but they're not harmless. And certainly in someone who already has the predisposition of being bipolar, smoking marijuana can be the precipitating event that activates it.
Wow.
And brings forth the first episode. Whereas maybe the person wouldn't have had a first episode, or at least wouldn't have had it at that time. There's certainly other things that can precipitate it, sometimes stressors such as, some sort of family illness or family death, or, some sort of economic stress or something like that can also be things that precipitate the onset of it. But definitely drugs can precipitate it. Now, So if someone becomes bipolar after using drugs, and it can be not only marijuana, it can be cocaine, crack, flaca, all these things that are in the streets, that person was probably already had the predisposition of being bipolar. So the drug did not necessarily make them bipolar. However, having said that, and again, this is where the history is important, and where, where using drugs is not a good idea anyway. There are certain drugs that can cause and mimic symptoms that someone would think is a bipolar person. Certainly cocaine, crystal meth, or other amphetamines, other stimulants such as flaca, or like the bath salts that you hear about in the news. These things can cause the person to behave in certain ways that would look like a bipolar person. And we would really probably would not be able to know the difference until that person is completely sober from drugs for a period of at least a month and a half, where we know that there are no drugs in the system, and then where we can kind of differentiate, what's going on, what's left.
So once you've been diagnosed, and I know, that would take you doctors working your magic to figure out what's going on. Is the only way to treat it through medication? Is medication inevitable?
Yes. If it's not the only treatment, and certainly there are psychotherapeutic and behavioral measures that are very helpful, and I'm sure we'll talk about it more, and probably Ms. LaGuerre will talk about that more. But definitely medications have to be part of the treatment. Regrettably, whereas, for example, people with depression, you can treat depression just with therapy, with behavioral measures. Exercise is very important. You don't necessarily have to treat depression with medicines. Sometimes, though, if therapy is not enough, then usually medicines can be helpful, and both together can be very helpful. But in the case of bipolar disorder, yes, you do need medication. Medication has to be part of it. It's not the only thing, but it has to be part of the equation. Yes.
Yeah, you hear a lot when people go off their meds. And when they're asked why they go off their meds, it's because they don't like the way it makes them feel. What is that exactly? And is there a way that they can be weaned away from the meds, or like you're saying, they have to stay on the meds for life?
Well, I would say that if someone, so let's take somebody, for example, who has been diagnosed with bipolar disorder for the first time. If they had only one episode and they get on medication, and eventually after several months, and that's important, that the medicines for bipolar depression, for bipolar illness, and for schizophrenia, they can start working within a few days of you starting them, but they really don't have their full effect until weeks or even months after you start them. So being compliant and taking the medicine every day is very important. Many times we get patients that say, "Oh, medicines don't work for me," but when you ask them, they say they only took medicines for about a week or two, and then they didn't feel any difference and they stopped taking them. And I say, well, that's not enough time for it to even start working. You have to give it time. But back to your question, I would say that if someone is diagnosed with bipolar, and we know for sure that it was bipolar, once they stabilize, once they've been on medications for some months and they're doing well, you can certainly do a trial of tapering off the medication
Mhm.
and see how they do without medicine. Some people, may never have another manic episode in their life, and do well. What does happen though many times is that eventually you taper off the medication, and maybe not immediately, maybe a year later or 2 years later, another episode hits. And then in that time, then we have to restart medication. I would say that you can probably, if you've only had one episode, you can probably try to come off medication and see how you do it. And there's a chance that you may never need it. But I would say that if someone has had more than one episode and they taper off medication, and then later they had a different episode and they had to restart treatment again, I would say at that point that the safest thing is just to remain on some medication. Yeah.
All right. I'd like to pull Joelle in at this point. Joelle, let me ask you, what is positive psychology?
Okay. So first of all, I want to say in the context of bipolar disorder and schizophrenia, positive psychology is typically not the avenue. So I want to start out by saying that. And Dr. Perdomo, I actually have some questions for you more so about how positive psychology can really fit in with of course, medical treatment. So that said, positive psychology is somewhat described as the non-traditional approach to psychology, where the traditional approach is looking at the relief of mental illness or mental disorders, however you would like to put it. So positive psychology is a fairly new subfield of psychology that proposes to focus on living a happy life. And sometimes it's called the science of happiness, which I think does it a little bit of an injustice, because sometimes it's seen as just, oh, we're talking about happy, happy, joy, joy. But what it's proposing is that fulfillment, thriving, flourishing in life is more than the relief of mental illness, right? For someone who is, of course, suffering from mental illness, that is priority, right? Relieving the mental illness, but the relief does not necessarily equate to a flourishing life, a thriving life. And what a lot of the positive psychology literature has mentions, though, and Dr. Perdomo, this is what I really like to hear your thoughts on, is that some of the concepts of positive psychology, which are about positive emotions, being engaged in your life, having meaningful relationships being key, and, accomplishment. Some of the things that perhaps we know kind of subconsciously, if not consciously, are the keys to leading a meaningful life. If that is prioritized, that can minimize the symptoms of some mental health challenges. And I don't think we say that too strongly, but I think that's suggested in a lot of the research. And I don't know about the research so much with bipolar disorder and schizophrenia, but certainly for depression and anxiety, positive psychology is often talked about as a way to kind of manage the symptoms of those disorders, and perhaps even for those who those illnesses are more situational than genetic, that it can sometimes prevent it from surfacing. And so when I was listening to you, Dr. Perdomo, I was thinking, would you suggest that attending to some of those concepts, like, making sure that you're living a meaningful life, that you have very strong relationships, that you're managing stress as best as possible, might that help to reduce the onset of bipolar, or is that a little bit too hopeful, if I would say that?
That's a very, very good I don't know, it's like a very, very good concept. I would say that I agree. And I would say that I don't know if I don't know of any specific long-term studies doing like measuring morbidity or mortality, but sorry, for everyone, measuring like outcomes in people with specifically with schizophrenia, bipolar, with emphasis in positive psychology. I can tell you that at least anecdotally and through case studies, I can tell you that it can definitely be very helpful. I think that that part of psychology, where we're looking kind of like at kind of like finding meaning, finding purpose, is an area that it's something that we have been, like you said, it's something that we have known maybe unconsciously for a long time. And they're very, very, and we know already its benefits when it comes to depression and anxiety and PTSD. There's this great book by Viktor Frankl, who was well, I'm sure. Okay, so yeah, he was a psychologist who was a Jewish person in the Nazi Germany, in the camps, and he wrote a book, A Man's Search for Meaning, I think is the title. So definitely, and I think that many of our patients who have bipolar and schizophrenia, part of the problem is that those illnesses do decrease a person's functionality, where maybe somebody who used to be straight A student, 4.0 average in college, doing their masters, like really smart person, once they develop schizophrenia and bipolar or bipolar disorder, they can become, it actually affects their mental capabilities, regrettably. And as the illnesses continue, sometimes, not so much with bipolar people many times they can function very well with their medication. But schizophrenic, sometimes they can never quite function at the level that they did before. They can, whereas maybe they were able to handle maybe some high stress, high complex job, maybe they can't quite handle that much. So there is a certain part of the illness is the loss of that purpose. Whereas before I used to be this, and I was able to achieve this, and my life, I was, I woke up every morning to go to that job, and so many times they're not able to continue the job that they were doing, but many times they kind of like regress almost too much, when then they're not functioning at all. And sometimes they have to go on disability. Sometimes their family has to maintain them. They're at home, nothing to do. And I think that definitely positive psychology can be very helpful in helping people find a meaning, maybe helping people see things a different way, and maybe find a new purpose, where maybe you're not quite able to do quite what you did before, but maybe there are other things that you can do, and you can still enjoy your family, you can still enjoy your life. And I definitely think that not only can reduce some symptomatology, it can reduce the stress and can decrease the severity or the frequency of recurrences of the illness. But also it can also make the person be more open to taking their medications and be compliant with the medications and go to their appointments, because it's not just about taking the medicine anymore. It's about, let me just get my medicine so I can be well enough so then I can do these other things with my life. I know that if I'm sick and in the hospital and going into the hospital all the time because I don't take my medicine, then I'm not going to be able to enjoy my life in this other way. So if once you have a purpose and a meaning, that's so important. And that can make the person just kind of like take more ownership of their life, of their health, and kind of like want to be better. You know what? I'm going to take my medicine because if it keeps me away from the hospital, and if I'm able now to do this sport that I like or do these activities, then, you know, and they feel more fulfilled. So definitely, I think that it's an approach, and I think it's something that is many times missing in the treatment.
Thank you. Thank you. Great answer. Appreciate that.
So, Joelle, in hearing the two of you talk, it seems like this would be a marriage of medical and psychological, and working together to streamline the person into a better life function. But the other thing, when I was reading your bio, I was wondering, apart from being fascinated with what you do, because I didn't understand it, you mentioned working for organizations and things like that. How does what you do in psychology benefit the organizations?
Yeah, so that's becoming increasingly relevant in 2021, all right, as so many individuals are experiencing increased levels of depression and anxiety. And I don't know if we're seeing higher incidences of bipolar disorder and schizophrenia. I'd be interested to hear about that as well. But organizations are recognizing that the well-being and mental health of employees is pretty directly related to productivity. And also retention, holding on to people, because if people are sick, or if they're just disengaged and dissatisfied, suffering from depression and anxiety, they're more likely to either leave or to, again, just not be as productive as they could be. So businesses always have the business in mind, of course, and we can't expect much more from them, but it is beautiful to see now that organizations are investing more into the mental health and well-being of their people. So while I'm not a clinical psychologist and I'm not offering that type of service to organizations, I am seeing them ensuring that within their healthcare programs, that things like EAPs, employee assistance programs, are there to kind of help funnel people to the appropriate services. And sometimes that is clinical help, and sometimes that is something like a coach like myself, which is not clinical but often serves to provide that kind of counseling-like perspective, and as Dr. Perdomo highlighted, kind of enhancing changing their perspective, enhancing their sense of meaning and purpose, which also drives productivity and retention on the job. So that's why organizations are so interested in it. And so a lot of the work that I do with organizations is coaching individuals, but also kind of applying positive psychology principles to the organization's, structure, design, and functioning overall, because we're learning that, just power dynamics, team structure, team dynamics, all of those things contribute to people's sense of meaning, sense of purpose, belonging, all of the negative side of that is that it contributes to stress. And I wonder, again, a question that I'd be interested, Dr. Perdomo, is to what extent do you see work-related situations being some of the triggers that drive episodes. I really don't know, and I'd really be curious about that. I know my familiarity is certainly more with depression and anxiety, and I know for sure that work situations often contribute to that for leaders that I coach. But I'm wondering how that contributes to those other mental disorders, because it sounds like you're making a distinction appropriately, probably, between depression and anxiety, which most of us are familiar with either as a clinical disorder or just as a every now and then experience. You're making that distinction between those and bipolar and schizophrenia. But I know they're all classified as mental disorders to some degree. And I know, again, that work or employment situations are a huge trigger for people, especially now when we're seeing things like layoffs and people having to make career changes is causing a lot of stress. So I'm curious, Dr. Perdomo, how do you see that, if at all, contributing to bipolar and schizophrenia?
Is it okay if I answer?
Oh, absolutely.
Yeah.
Sorry, Marie.
Oh, no. I talk a lot. I don't want to, I'm going to try to not talk so much. I don't want to take, and thank you for the question. I appreciate it. No, it's one of the main stressors for everybody, work-related stressors, because work is it's part of life. We work and that's how we make our living, and that's how we make money for our family, and etc. I am making a distinction between depression and anxiety and bipolar and schizophrenia, because depression disorders and anxiety disorders, as you will know, and you mentioned it earlier, can sometimes just be situational. Someone who is, fired from their job and who is homeless, they're going to be depressed, they're going to be anxious, but that's not necessarily, that's a different type of anxiety and depression than the person who seemingly has it all and still suffers from major depressive disorder. That's a different type of thing, and that in that one is more biological, it's more genetic, and it actually contributes to their guilt, because they say, "Why am I so depressed? I have nothing to be depressed about." But putting that aside, definitely bipolar and schizophrenia are apart because they're not situational only. Certainly situations can bring them forth and can precipitate an episode. If you've been stable, but then all of a sudden you're stressed because your job, they just make you, now they change your job description, and now you're dealing with a lot of things you didn't know how to deal about, and you get very stressed, that can certainly bring forth a new episode of bipolar disorder or a new episode of schizophrenia. But the cause is not just situational. You have to have the genetic component to it. I will say that we probably see more in more high-end jobs that do sort of the coaching that you work in. Besides seeing a lot more depression and anxiety than bipolar schizophrenia, I would say that probably you would see a little bit more bipolar than schizophrenia, because bipolar people many times can continue to function close to their prior level prior to getting sick for the first time, or at that level, or at least close to it with medication. Bipolar disorder many times doesn't quite affect the functioning just as much. And I apologize, my daughter's with me, so if you see a head every once in a while, it's just my 5-year-old daughter. Anyway, but people with schizophrenia, usually once they have their first break, like I said earlier, if they had like a very high functioning, high-end job, a complex job, they may never be able to quite reach that again. So like someone who's been schizophrenic for 5-10 years, you're probably not going to see them in
Okay,
a.
can I just
Oh, I'm
break in
sorry.
right here? No, because you're going into schizophrenia and
Oh, I'm sorry.
no. Because that goes in with the questions she was asking. But because I'm trying to make sure that everybody's understanding, let us talk a little bit about schizophrenia. Oh, I finally understand what bipolar is. So let's talk about what schizophrenia is so that they can have that correlation about what you're mentioning and what Joelle was talking about. So what is schizophrenia?
Okay, so schizophrenia is another mental illness. People with schizophrenia, whereas in bipolar disorder, like I said, it's more mood. It's more either depression or anger or excessive happiness. Schizophrenia, people with schizophrenia have more of a break from reality. They have schizophrenia. The main issue is that you have psychosis. Now, what psychosis means is just any break, any sign or symptom that shows that someone is kind of breaking from reality. So what do you mean by that? There are probably three main things. Number one is delusions. Delusions are false beliefs that a person has. So people with schizophrenia many times have delusions. They have beliefs that are not true. They believe things such as that that they are a secret government spy and a secret mission, and that the government or the CIA or the mafia is following them. These are people that sometimes like they stand inside their house looking out the window, and any car that passes, they say, you see that car is following me. You see that person over there, that person is spying on me. They can have beliefs like that. They can have other beliefs. They can believe that they can read people's minds, or that other people can read their minds. They can believe that other people are communicating through them, telepathically. They say things such as, oh yeah, I talked to whatever person. I'm talking to him right now. They believe, so that's delusions. So then there's also what we call hallucinations, which is when you perceive something with your senses that's not really there. And the most common hallucination that people with schizophrenia have is auditory hallucinations. They hear voices of people that are not there, or sounds that are not really occurring. They say things such, oh, don't you hear those cats meowing? And you're like, no, I don't hear any cats. Or they hear people talking as if they were in their vicinity. People with schizophrenia many times have a lot of like what we call religious preoccupations. So if they're, if they're believers and follow a religion, it's not just obviously having faith, or not just obviously saying like how many people say, when I pray, I hear God in my heart. All that is fine. But people with schizophrenia can sometimes like believe specifically that angels or God or the devil are actually talking to them in real time at the moment. and they command them to do all sorts of things. And it's usually very strange things. It's not just go and give this person a hug. It's usually very a lot of convoluted and bizarre commands. So they may like take their clothes off in public, or they may start randomly shouting things, and they say that that's what God is telling them to do, or sometimes it's more malicious than that. It's more like they hear the devil and they think that the devil is talking to them, telling them to hurt themselves and hurt somebody else. And then the third thing, so we have, like I said, the delusions, which are the false beliefs. We have the hallucinations, which are usually auditory. People hear things. Sometimes they can see things as well and feel things, but the voices are probably the most common in schizophrenia. And then the third one is what we call disorganized thinking. And that is that the person, many times they talk and they don't even make sense. You can't even really understand what it is that they're trying to convey to you, because they're just saying random words or random sentences. They're saying things that just don't make sense or incoherent things. Their actions, they do a lot of bizarre, random actions, like randomly breaking something, or doing their necessities in front of everybody, or just this sort of breaking things and just like throwing everything away. Like, and anytime that somebody does a lot of bizarre things that are just very random and very strange, and when you try to talk to them, they're just maybe they can be rambling on and on, but they're not even making any sense. That is also a potential symptom of schizophrenia.
Okay, just for the interest of time, because this is I always knew these subjects are huge. Going back to the treatment, let me start first. Are they born like this? Is like how you said bipolar, there is an hereditary trait? Or okay, with schizophrenia, is this the same thing?
It is the same thing. It runs in families as well, but sometimes it can happen randomly in somebody who didn't have a family history. It is also, there has to be a genetic predisposition. It works the same as bipolar, in the same sense that, because both bipolar and schizophrenia, even though you're born with the possibility of it, you don't usually manifest it until late adolescence or early adulthood. That's the most common time. And in the same way as bipolar, there are certain things that can definitely precipitate it, like a stressor, or like the use of drugs, can certainly be and the same as bipolar, the lesson here is the same as well. There are certain drugs that can mimic some of the symptoms of schizophrenia. There are people that use cocaine and then they become very paranoid and they start hearing things and seeing things. There's this new synthetic cannabinoid substances on the street. You may have heard some of these names: Spice, K2, some of these names that people say on the street, but these are like synthetic cannabinoids that are even stronger than regular pot. And they can also cause people to have some of these symptoms, and they can persist for many days or even weeks. So again, you have to make sure, so it can certainly be confused for schizophrenia or bipolar, and you have to kind of make sure that somebody is sober for a period of at least a month and a half, if you suspect that the drugs could be the cause before you can figure out what's going on.
Okay, so they're channeled more or less the same way. What can cause one can cause the other. I guess it's just a matter of what gene, what hereditary things that you to see what avenue it goes to. And going back to what you were saying to Joelle, you were saying something about bipolar people can manage on a job better than schizophrenic people because theirs is not as bad, or they're better able to cope than.
Yes. People with people with schizophrenia, eventually with time, it's kind of like their higher end thinking kind of stops and kind of like regresses a little bit. Schizophrenia used to be called, way back in the day, used to be called dementia precox, meaning dementia, like an early dementia, because people with schizophrenia over time, even if they're stable on their medications, if they're not having like the delusions or hallucinations, they may never quite be able to handle the same type of job that they did. Bipolars can sometimes have that, but it's less frequent. Bipolars many times with medication and with proper treatment, they can many times work the same that they did, or at least closer to what they used to do.
So just for my own edification, the the people on the street that they look as if they have mental disorders, they would be more likely to be schizophrenic than bipolar.
I'm sorry, do you mean the people on the street?
The people that you see on the street that are not necessarily homeless, but they're walking and talking to themselves and whatnot, they would quicker be a schizophrenic than somebody with bipolar disorder.
Yes.
And for Joelle, for you, you could possibly work with a bipolar person, but it sounds like schizophrenia would be not somebody you could sit down and mentor and talk into a better way of handling things.
Perhaps. I'm wondering, Dr. Perdomo, is someone who is medicated, have you seen anyone who is, suffering from schizophrenia, undergoing treatment, who is able to kind of live what we might consider a normal life, whereby we could talk about purpose and meaning and things like that?
Yes, yeah. There are levels. I would say that there are some schizophrenics, especially. It depends also when you catch them. I would say that someone who's been schizophrenic for 15, 20 years may not be able to necessarily benefit that much from that, but certainly someone who's early and earlier, and certainly there are some schizophrenics that are a little higher functioning that can benefit. But I would say even the ones, because what I've seen many times, like I said, is that there are people who, maybe they're never able to go back to the job that they were doing, but they can still volunteer, or they can still get a job, working, in a store, just stacking shelves. It's not, maybe the job that they had before, but it can still be a job, and they can still have their hobbies, and they can still, sometimes some of these people may not be able to work, or not be able to work full time. Many times they actually on disability. But I've seen many schizophrenics who within their illness and within their limitations lead a pretty normal life. They handle, they receive the disability money. They have maybe a part-time job. They handle their finances. They buy their food and they're close, they go to their appointments, they have family, and they get together with their family and their friends. So it definitely, I think that everybody can benefit. I think that the distinction would have to be, and that's something that you would do depending on each patient. You kind of have to manage expectations. There are some people that will not be too high functioning. So you have to kind of like bring it down to the level. But I definitely think everybody can benefit from it. And meaning is important. Meaning is important. Having something to get up for, and something else to look for, something bigger than yourself. And also, this is where, for example, having a good church community is important as well. Because you're giving yourself for something that's bigger than yourself. So it can be very helpful for them. Yeah.
So tell me now, because we're totally out of time, and I could talk for another several hours on
Yeah,
this.
I know. There's a lot of stuff.
Yeah. If what, as briefly as possible, if someone came to you and said, my family member, my friend is exhibiting certain symptoms that I'm concerned about, what would be the first thing you tell them to look for, and the first thing it should do about it?
Okay. So I would say that the main thing, I would ask the description of what's going on exactly. Things to look for, again, are they not sleeping at night? They spend most of the night up, or sleep very little and don't feel tired? Are they doing a lot of excessive activities, just one thing after another and never finishing anything, leaving everything? Are they just very, the things I'm saying are things that will probably happen in bipolar disorder.
Mhm.
Are they very irritable, just very nasty? Another thing I would tell patients is, or their families is, can they afford to have an episode? Because many times they just spend money excessively, and on things that are not like random things that are not important, and spend excessive amounts of money. Or in the sense of bipolar, do they seem like they're talking to themselves all the time, just murmuring to themselves or reacting as if something else is happening? Are they having strange behaviors? Do they not make sense when they talk to you? Do they say stuff like, that they believe that they're famous, or that they believe that they're rich, or that they believe that someone's after them? I would say those are probably more the common things. The first thing I would say is that I would try to have them, I would say, ideally, get an appointment with a mental health professional. Now, sometimes that can be difficult, and sometimes those appointments, it can be hard to get them. So I would say, if it's something that is very pressing, that it's causing a lot of dysfunction in the family or in the home, I would say that the main thing would probably be, I would tell them, just take them to any ER of any hospital.
Oh, okay.
Because if the hospital has a psychiatric unit, then they have psychiatrists that would be able to assess the person in the ER. And they would be able to, once you have a psychiatrist that sees the person, they will be able to orient the family and say, okay, you need to do this, or listen, he or she is too bad right now, we need to admit them, depending on what it is. If they go to an ER and there's no psychiatry service there, but the person is severe enough, then the doctors in that ER are going to fill out what's called a Baker Act, which is a type of document in which somebody is admitted, somebody is held on what's called an involuntary hold, and they are sent to a facility that does have a psychiatrist to assess the person. I would say that if the person's behavior is especially dangerous, if they are being very violent, very aggressive, if the family feels that maybe their safety is at risk, or maybe the person's own safety because of their actions is at risk, you can always call 911 and explain situation. They're gonna send, if for mental health illness, they always send an ambulance, and they always send police to get the person. And if they think that the person is too severe and is a danger to himself or others, then they will do themselves the Baker Act, and they will bring the person to a facility that has psychiatric services, so then we can assess the person. Many times going to an ER or calling 911 is probably the fastest way, especially if there is something very urgent going on. If it's not that urgent, then maybe if you can wait and just make an appointment with a psychologist or psychiatrist, then you can do that.
Okay. Joelle?
Sorry, there is a question. The question is, do you observe these conditions in one gender more so than another? And are the treatments different?
I would say that they are pretty evenly matched. Schizophrenia seems to be a little bit more frequent in men. I honestly, I don't remember at the top of my head if there is a slight in which sex you can see a little bit more bipolar disorder, but I would say that overall they're pretty evenly between sexes. There is not, being male can maybe give you a slight increased risk of schizophrenia versus a female, but we definitely have a lot of female schizophrenic patients, so it's not a particular thing. In terms of treatment, the treatments are pretty much the same. The only thing is that if when we're talking about a woman of childbearing age, a woman that could potentially become pregnant, there are some of the medications that are used for bipolar or for schizophrenia. Some of these medicines can sometimes increase the risk of certain malformations in a baby. So there's certain medicines that if it's a woman that it's between her teens up until maybe the late mid-40s or something like that, where the childbearing age, there are certain medicines that we would not use or before we have to make sure that the person is not pregnant. But other than that, the treatments are the same.
Okay. Joelle, what would you recommend to someone who came to you? And, how would you talk to somebody who, was exhibiting?
Yeah.
I know for you, schizophrenia would be definitely what Dr. Perdomo was saying, going to the ER, but maybe for a bipolar person that was maybe just had their first break and is kind of evened out through medications, how could you help the family handle whatever is going on?
Yeah, I think what would be most important is to understand that individual and perhaps that family's how they're responding to it. Because it is a diagnosis that I imagine can really devastate people because they may foresee themselves living a different life than they had initially. And I would say, even so, for someone who is struggling with schizophrenia, if they're at a place where they can, manage a coaching conversation, I think I would really focus on the conversation on right? How is your life different now? What's your vision for your life now? And how we can make sure that those things that, positive psychology tends to focus on, mindfulness, resilience, really meaningful relationships, purpose, all of those things are a real central part of their lives, because they're going to need that perhaps more so than ever to really manage through this illness. So that's what I would say.
Thank you, thank you, thank you. Dr. Perdomo, you broke it down for me that I really do understand now, because you heard these things and you kind of think you know what they're doing, and this for me really put them in their categories, and so that I could possibly, even if I saw it, say, that person is going through bipolar, because yesterday they were so depressed and today they're moving mountains, or that person is talking to themselves, maybe they're schizophrenic. At least now I have the two separated in my head. Your explanations were on time. Thank you so very much. Joelle,
excuse me.
Yes.
Excuse me. One more thing. Do the genders seek treatment at the same rate?
That's actually a good question. I'm trying to think. I can't remember. I think that studies usually show that women usually are a little bit more proactive in seeking treatment. And I think that's across mental health issues in general. I'm not sure why. I think it may be just part of just maybe how women are raised, in the sense that usually women tend to be a little bit more family conscious, and just a little bit more dare I say realistic, whereas sometimes us guys, it can be like our heads in the moon, whatever. So and yeah, I think that there's certainly, at least anecdotally from what I've seen, there's certainly an element of the same way that guys don't usually like to ask for directions. I think that's the same day of like, I can handle this by myself. I don't need you. This is just normal behavior. Guys sometimes I get angry, and that's fine. That's just how I am. I think that definitely probably women are a little bit more proactive in seeking help and in being compliant with medications. If I may just say something very quickly, because Maury, you mentioned something earlier that did not that I didn't quite touch upon, which was when you mentioned that sometimes people like come off their medication and they say, "Oh, I feel bad with this medicine and I don't want to take it anymore." And it kind of ties into this. Definitely, even though maybe women are, I would say, they're a little bit more compliant and seek out help more, there is still a big issue is compliance with medications in both sexes. Maybe men more than women, but in women it happens as well. Part of it is just the new reality. Nobody wants to be a schizophrenic, or nobody wants to be a bipolar. Your life was going fine up until this came up. So many times it's hard to accept it, and it's hard for the family to accept it as well. So maybe, whereas they don't have the usual family saying, "Yeah, no, go take the medicine." Sometimes the family themselves don't quite. So that's one of them. These medicines, they do have some side effects. Some of these medicines can cause weight gain. Some of these medicines can increase your blood sugar or your cholesterol. So definitely that is an issue that can make people sometimes not take their medication. And we try as much as possible to give a medicine to someone that's going to cause as little side effects as possible. Some of the medicines sometimes can make people drowsy or lethargic. And so I can tell you that as a doctor, one thing I tell to the patients is, listen, if you have a problem, come to me, tell me what's going on, and we'll see if we can adjust the medicine. You know, sometimes we can minimize the side effects. Sometimes some side effects remain, and that's a sad reality of it. In those cases, what I tell people is that, yeah, you now may have to deal with these side effects, but it's better to deal with that than to deal with a situation where you're just not functioning, when you're just not able to have a life, and or you're a danger to yourself or other people. And then the last thing, and this is specifically for bipolar, that you're going to see a lot, is that sometimes bipolars don't like to take their medicines because when they're manic, when they are high, have excessive energy, they're very happy or they're very angry, but they have this excessive energy. They feel that they can move mountains, like you said. They feel like they're on top of the world, that they're the best at everything. And that feels good. So then when you actually start treating them and they actually start coming down back to normal, they actually feel bad and they feel down and say, no, I don't want to feel normal. I want to feel like how I did before. And it feels good for them, but they're not functioning. You know, they maybe they feel that they're great, but they're staying up all night and destroying the house and doing all these things but sometimes it's hard for them to see it because they feel good when they're high, when they have that. It's a natural high. So many times they come off the medicine because they're brought down to normal, and normal doesn't feel good enough.
Okay, thank you. Claudia, were there any more questions coming through? I guess not. Well, Joelle, again, I kind of wish our EAP had you at my job, because I think you would have helped a lot of us when a whole lot of changes were going on my job. I just really thank both of you for the knowledge and the expertise you brought to this program. I pray that, hi, pretty girl.
Hi.
I pray that somebody somewhere benefited from it. And I just want to thank you all because, yeah, I've learned a great deal from this program. Thank you so very much.
Thank
So,
you.
Thank you.
Many times we look at people with mental illness and we wonder, what did they do to cause it? And what should they have done to prevent it? But this program has made me realize it's not that cut and dried. And a lot of us blame ourselves and think if we prayed more, like you mentioned, Joelle, if we prayed more, if we did more, if we talked more. But I'd like to say this. For those of the Adventist religion, they know Ellen White. And I don't know if everybody knows that she suffered from depression. Another form of mental illness, but sometimes she had severe bouts of depression. And she said that there were a variety of causes for depression beyond physical illness, including diet, genetics, guilt, inactivity, and the weather. And this came from a non-medical, minimally schooled individual that had no training in that area, but was able to notate things that took doctors years to decipher. And Dr. Perdomo, that goes in line with what you're saying. Now that the studies are going through, they're finding out that genetics is a part of it. And she said this so many years ago, before this was knowledge, general knowledge. So the other thing that I'd like to really, really bring across to everybody, mental illness can affect you. It can affect me, anyone, at any given time. And if you have that knowledge in your head, when you see somebody who's suffering a mental illness, who is struggling with depression, who is struggling with bipolar disorder, look at them with your heart and not your head. My mother used to tell me, when you look at somebody that's worse off than you, think therefore, but for the grace of God, go I. And if you look at life that way and just be sympathetic, but also be grateful that this has not been visited on you, I think it will cause a softening and a more need for understanding. And that's what I needed, was a better understanding of mental illness. There's so much more I don't know, but at least for this little session, it did give me a baseline that I could start and understand. And I thank you both for that. There's a quote in the Bible that gave me a little hope. It's in 2 Corinthians 4, verse 8 and 18, and I'm paraphrasing. We are hard pressed on every side, but not crushed, perplexed, but not in despair. We fix our eyes not on what is seen, but on what is unseen, since what is seen is temporary, but what is unseen is eternal. Let's pray. Thank you, dear Father, for this program that has been very beneficial and very educational. I just thank you for the two experts that came on and volunteered their time and their education, and they're just so willing to help instruct us about these things that has opened our eyes to these mental illnesses that we should be more cognizant of, sympathetic to, and see what we can do to help a person who might be going through this instead of being afraid or ignoring them. Thank you, Lord, for this opportunity that you have granted us, and be with each and every one of us listening in, both here and in the future. Grant us peace, grant us understanding is my prayer. In Jesus' name, amen. Just before we leave, I'd like to remind you that the Women's Ministries Prayer Breakfast is August 8th. And in August, we have our End It Now program, starting with the last Thursday in Search of, August 26th, and then going through to our Sabbath hours on Friday the 27th and the 28th. So we're hoping that you will join us again for these programs. I wish you all a good night. We took a little bit more time, but I hope it was beneficial to everyone.
Thank you.
Now, so we color.
Yeah, you can keep on coloring now.
Look, so you gotta be.
Yeah, well, give me a moment.